Great. We're changing track now. We're moving to health economics, and I'd like to invite Patricia Marques, who's a health economist at the International Centre for Eye Health, at Jack Hennessy, who's the senior health economist from Fred Hollows Foundation Australia, to come and do the first of their two talks. We're going to pause between the first and the second to take some questions. So over to you guys.
Yeah. Okay. Sorry, I might need to go. Yeah, that's much better. Great. All right. Thanks so much for having us both here. Patricia and I are kind of going to do a little tag team session, as it's very much a collaborative project, not just between us, but between lots of colleagues, some of who are in the room. But the first thing we're going to talk about is a systematic review of essentially cost utility studies for eye care that we're working on. So as a little bit of a background, and I won't read each of these individually, but maybe for those of you in the audience who aren't health economists or who haven't necessarily worked too much with health economists, the way, fortunately or unfortunately, that many health interventions in the world are prioritized is through the use of cost utility studies. It's the way that a lot of governments and a lot of decision makers determine if an intervention might be cost effective or otherwise. In the calculation of these cost utility studies, we often look at things called disability adjusted life years and quality adjusted life years. And these are two sort of slightly foreign concepts for those who haven't looked at it before. But essentially the aim, when we're prioritizing different interventions, we want to look at the cost per disability adjusted life year, for instance, averted. So what a disability adjusted life year is, it goes from essentially one disability adjusted life year is the equivalent of saving a year of life where a person has to live with zero levels of disability, which is, again, a bit of a hard concept to understand. But the most critical thing in this disability adjusted life year calculation is a thing called a disability weight, which is derived through the global burden of disease studies led by the Institute of Health Metrics and Evaluation over in Washington. But what's happened with eye health, as probably a lot of you are aware, the disability weight associated with blindness and other levels of visual impairment has actually decreased over the years. So if you think about a disability weight from 0, which is living with, perfect health, essentially, and it goes to 1, which is someone who is dead. As crass it is, that's how these are calculated. So eye health has slowly sort of had their disability weight associated with it. It's been eroded over time. So it's gone from about 0.6 in the last iteration to down to about 0.18. Okay, this is a really long, rambling way to say that part of the reason that eye health interventions aren't prioritized currently by governments is because of the disability weight associated with these. So we set out to find how these are calculated, why these are calculated, and maybe to see if we might be able to influence change of this a bit later on. So the aim of our review was to identify and compare disability and quality of life weights. Thank you, John Cairns, for allowing us to include quality of life weights, because as you'll see in a second, that ended up being the vast majority of the studies. Using cost utility studies, so studies that look at cost per QALY or cost per DALY associated with the 5 leading causes of visual impairment.
And just to add, just to add that we had a few conversations with other team and from other conditions, and everyone is upset somehow with the wages, but we decided to do it systematically. So we decided to do a systematic review and put everything together and analyze the results in a systematic way, so we could have a more scientific way of saying we think something is wrong here. So how did we do this? So we followed the usual procedures on the systematic review. We searched studies in several databases, and we decided, like Jack explained, to include cost utility studies reporting quality adjusted life years and disability adjusted life years. And our time frame is from 2024, so 24 years of research around this. The search strategy was constructed by an information specialist, which is very important because we use different databases. And as an inclusion criteria, we included cost utility studies for clinical interventions on the 5 leading causes of vision impairment. So we just look for clinical interventions, which is important. As an exclusion criteria, we excluded systematic reviews or other evidence synthesis, but we did look at the references of these systematic reviews to be sure that we covered all the studies that were published with these inclusion criteria. So sorry for this is a Prisma flow, just to let you know that from a total of 3,694 studies, we were able to, after screening titles and abstracts, we had 288 studies to go for full text screening, and we ended up including 2,033 studies, which is a lot for a systematic review. As a high-level results, and this is still a working, we're still working on. So we found that from 24 years, 66% of the cost utility analysis were published in the last 10 years. So we have a lot of recent papers. 79% of these cost utility studies were published in high-income countries, and we have the UK and the US publishing almost 50% of our studies. The majority of studies analyzed cost utility interventions for DR, AMD, and glaucoma. And this was a big surprise for us. 97% of the studies used quality adjusted life years. And we were expecting to have more disability adjusted life years. We also saw that 52% used Markov models, which is a good sign to see that we're using more evaluated
level of rigor.
Yeah. And the models. And also we have a big percentage of papers on screening, I think around 28%, and surgical procedures as well. So these are our high-level results, and we're still working on the sources because we have so many papers on quality-adjusted life years. We have a big task of to know more about the sources that were used here.
So I know we're probably running tight on time, but some lessons that we learned, I think we thought there would be like 60 studies or something like that, and we ended up doing data extraction for like almost 300. So we had to bring in a few more team members to get that over the line. Data extraction is slow. I'm sure there's lots of people in here who've done a systematic review before. I was complaining about it myself yesterday because you are really excited at the start of it, and then suddenly you've got 60 papers to look at individually, and they're all pretty similar. It's a bit of a hard slog to get through sometimes, despite how interesting it is. Consensus was a little bit difficult, so it really wasn't us comparing like apples to apples with all these papers, because the methodologies used and the terminologies used were so different across all of them. It was really hard to get consistency in the results. And you definitely need a multidisciplinary team to do this. I think this is just one sort of last slide here on the implications. And I guess to sort of summarize, we came into this project thinking, GBD are wrong. Like probably lots of people in this room contributed to the GBD weights, but I'm not saying you did anything wrong. But this, as Patricia mentioned, like there's lots of different disease groups that are saying, hey, our disease that we're focusing, eye health's way more important than hearing. Hearing's more important than something else. But no one has really systematically reviewed them like this. And in a way, it's been, I guess, somewhat pleasing to find that our hypothesis does hold a little bit. A lot of these papers, the disability weights or the quality of life weights, are based off very few studies. Brown, I'm not sure if there's anyone called Brown in here, but Brown seems to have written a few of them, and they're almost all derived from that. So these governments are prioritizing interventions based on a very small, finite number of studies, which is giving us lots of motivation to continue to the next phase, which might look at experimentally adjusting some of these. And thanks to everyone in the research team, obviously.
Great. Thank you, both of you. That was brilliant. Well done. Questions? Yes, please.
Hello, I'm Devanand. I'm from LV Prasad Institute, Hyderabad. Thank you for the very insightful presentation. In your study in evaluating the cost utility, how did you deal with uncertainty in utility estimates from low research settings?
So one of the pains of the data extraction form that we designed, we essentially, if they had used different weights in sensitivity analyses, we noted all of those. We noted the lower and upper values of all the parameter point estimates for the weights. So we've essentially got all that information, but again, I wouldn't say it was necessarily common for papers to have done sensitivity analysis to deal with uncertainty. I would say it was probably the exception rather than the rule. I'm not sure if you have anything else to add.
Okay, thank you.
Yeah.
Super. Thanks very much. Any other short burning questions? Because we do need to move to the second talk from these guys. Yeah, behind. Yeah.
Hi, I'm Rajiv Ramchandran. I'm just wondering, is there any other specialties out there, cardiology, cancer, that are doing this, and can we emulate them in their work?
Not in a systematic review, not that we are aware of. So we had a conversation with other groups about doing this, and they all seemed very excited and said, "Oh, this is a very good idea to do it like this," because as we aim to say, these are the methods behind the sources. These are the advantage and disadvantage of using these specific sources. In our opinion, based on what we found, we think that to do a better job with the disability weights and with the quality of life weights, we need to use specific methods. So I think, I'm not sure if I've answered your question, but no.
Can I add one thing really quickly? Sorry, just also to say there's I guess this kind of law that or like rumor that the hearing group, some sort of hearing advocacy group, managed to lobby successfully to change the disability weights like a decade ago or something like that. And I know LSHDM have had a few conversations with them, but it seems to have been a matter of circumstance. Like someone had a child who was deaf or something like that, and it ended up going through like that. But again, as Patricia said, not in a systematic way like this.
Great. We're going to move to your second talk. Perhaps if we have enough time at the end, we can come back to what do we do about this problem? Yeah. Okay, because that feels to me to be like the elephant in the room here. Right, number two, you guys.
Cool. See if we can be quicker here. So yeah, we're changing gear a little bit here from a very much a systematic review, secondary data, to kind of the opposite, like ultra primary data that we're kind of starting to collect as we go along. So this is about a health economic module that we're developing for the use with RAB. So as I've kind of said, talking to a number of people over the last few days, we know that eye health interventions are cost effective. For the majority, especially when I'm talking about cataract surgery and refractive error, we kind of hang our hats on that. They're some of the most cost effective interventions in the world. But if they're so cost effective, why aren't governments prioritizing these things? We've already talked about, quality of life weights, disability weights. Yeah, that comes into it. But what if we could show that eye health interventions contributed to more than just an improved health of your population? And what if eye health contributed to economic development? So this is something that, the LSHDM team and a lot of people in eye health have been talking about for a while. But one of the main things that's been called out upon is the lack of a consistent estimate of the impact of eye health on workforce productivity, on absenteeism, on presenteeism for paid, informal, and unpaid labour. And so this is something that we sort of set out to address in developing a health and economics module, and connecting it to RAB was, in our opinion, the way forward to lead to more consistent context-specific evidence collected across each country. So the aim, I guess, of this study was to sort of develop a context-specific estimate of the economic impact of eye health. And that's the aim of the overarching study, but sort of what we're presenting today is two pilots that we've done in the design of this health economics module. One was in India and one was in Burundi. And I'll hand over to Patricia.
So in terms of the methods, and I'll try to be fast, we started with a meeting with experts, so with an international network that we have to define the topics that we thought could be useful for us to collect data over individual data with RAB. And we like Jack mentioned, we ended up choosing employment status, absenteeism, presenteeism, health-related quality of life as well, and affordability. And what we did was we did a document review. We went to see the instruments that were being used in other areas to collect these topics, and we constructed our own questionnaire. And we decided to pilot it in two different settings, like Jack said, Burundi and India. So in India, we had help from Dr. Shroft. Thank you for helping us with this, to test in a hospital-based area. And we started there. And then we moved to Burundi within a RAB. So we wanted to see how the questionnaire would work during a RAB. And mainly what we wanted to do, what we wanted to learn was how long does it take to take the questionnaire? Are the questions clear? Does it cover all the options that are important in that context? And if it's valid and reliable. So we want to know more about the validity and reliability of the questionnaire. And we also want to know how does the data we collecting compares with official statistics on the country to see if we're getting where we want. So in terms of the results, we had 31 responses in India and 225 in Burundi. We have a good distribution in terms of the levels of vision impairment, a good distribution of gender, and mostly rural areas, and a good distribution in terms of working age population, because we needed to have some insights about if people are working or not, because that was one of our objectives. And as a high-level results, and this is still a working project still, we had 19% of respondents that were in working age that responded to being employed. So this is comparable with, if we compare this with statistics of employment in each of the countries, we know that the level of employment for people with levels of vision impairment are low, as expected. And we have also a high rate of unemployment in our population. There's also a link between low health-related quality of life and VI, or worsening states of VI, which was also expected. And we've also learned something about affordability, knowing that in Burundi, affordability is a major barrier in accessing eye care. Not so much in India, but of course we were doing this in a hospital-based setting where people were getting help to get access to eye care.
So some more sort of lessons, results-based lessons, I guess. People with blindness and visual impairment was sort of distributed quite differently in each country. Again, we're just at the pilot stage of this module. So we were not doing random sampling or anything like that. We're very deliberately selecting samples within each strata group of people who might be older, people who might be living in rural areas, and people with differing levels of visual impairment. Educational attainment was different again between the two regions. The economic indicators showed that a high proportion of Indian participants had no income and rated themselves as poorest on the self-reported sort of poverty scale that we were using. Eyecare access was typically lower in Burundi, as well as being associated with sort of lower, I guess, financial protection. Some next steps, we're going to look at the validity of this instrument. So that's kind of what we're still trying to work out. We're going to look at the reliability. We're going to do some more data collection and some more analysis to see how this extends to unpaid work, those in informal labour market sectors, which are really, really important for us to capture throughout this project. We're also going to look at some formal sampling estimates. So when people are doing RABs, they really want to know how the sample size calculations work, and we want to try and figure out what exactly we need to get and who we need to talk to be confident in these estimates. And again, down the track, we want to incorporate this formally into RAB so that countries can choose it as an optional module. I guess reflections here, I think developing the module on the fly a little bit has been a bit of a learning experience. We haven't had a heap of funding for this project, so we've got annoying Fred Hollow's funding rules to adhere to, where you have to spend it by the end of the year half the time. So we've kind of relied on a lot of generosity from Shalinda and Dr. Schroffs, and kind of piggybacked on the work that's already been going. Every RAB I hear about, I'm calling them up and being like, hey, can we test this health economics module on it? And so we're doing all those sorts of things that we have to do to make it work. But it has made things a little bit difficult, because half the time we're fighting for funding and half the time we're meant to be implementing the research as well. In Burundi, we did the training online because neither of us could go there, but we had a really good team on the ground, and that seemed to work okay. I don't think it's ever going to be realistic to have health economists flying out to every RAB that we want to implement this model. So that was kind of a good experience that we got from it. It's a little bit difficult to balance the rigor required for validation. So people who've worked in survey validation, you might know about like test-retest method, where you get the results and come back a few days later and see if they say the same thing. It's really difficult to implement those things when RABs are expensive. They've got a main goal of the RAB. They want to know the prevalence of visual impairment, and we're there nudging them saying, hey, why don't you ask them all these questions about whether they go to work or not? And so that's been a little bit difficult as well. I think there's still a lot of work to do, especially around the validity of this, but certainly it's our plan for the future to have this module as an optional module that a country could choose for RAB, and then suddenly we're getting all this context, country-specific evidence on the impact, the differing levels of visual impairment that impacts labour market outcomes, and I think that can really make a difference to the way eye health is prioritised. So thanks to the research team as well.
Great, thank you very much. Questions? Can we make the questions brief so we can...
Okay, thank you very much for the wonderful talk. Based on your experience, what do you think is the biggest challenge when you apply an economic evaluation concept to community eye care programs?
Very big question. Not sure it's completely related to what we're lacking here. For the RAB, we feel that it's very important to have individual data that can help us to make decisions and potentially use in economic evaluation studies. I think that's...
Yeah, and it's difficult because people who are doing RABs, they care, as I've said, they care about the prevalence, they care about the planning and the affordability. These things that we think are really, really important as economists, and not necessarily the most important for others. So implementing these types of questions, being able to fight and sort of show the value of this information has been sort of the hardest thing for me. Yeah.
Great. One other question. Sure.
Yeah, it was a very nice presentation. And just a question I had was, You mentioned that in Burundi there is no accessible services. So, looking at the blindness, it should have been that the prevalence or whatever you showed, the number should be higher there. But it is just the opposite. In India, the blindness was higher, though the services were accessible, right? So, how do we get about, because we think that when the services are provided, then they should be used and the blindness should be lower. But even though there are things there, what are still the barriers that people are not addressing those things, or they're not going to get those services? So yeah.
So we shouldn't look at the data to see prevalence. We construct a matrix of the respondents who we wanted to answer the questionnaire, because we wanted to learn if the questionnaire was clear for everyone. So we decided on rural areas, urban areas, men and women, and different levels of vision impairment. So we got lucky with India, because we ended up interviewing a lot of blind people.
So, in fact, we were supposed to collect patients of those categories.
Yeah,
So
exactly.
we waited till the category got filled. So it means we wanted so many patients of blindness category. It's not like anybody coming randomly was assigned to these groups.
Yeah.
I don't know whether it's clear.
So it's not prevalence of blindness. We cannot compare the prevalence of blindness in those countries based on these numbers. This is what the sample we use to test the questionnaire, if I'm making sense.
Great, thank you very much. Perhaps if we have time, we'll come back to how will we use this data once it's in RAB and what it will enable us to do. Back to me.